We now proceed to panel discussion 1, which is concerns over PEME standards faced by medical and manning sector, for which I invite upon stage our esteemed panelists in order, Dr. Dushyant Barfiwala, Medical Director, Dr. Ranveer Singh Clinic. May we have you on stage, sir? Dr. Vijay Belani, Medical Director, Dr. Belani's Blue Shield Medical Clinic LLP. Captain M.P. Bhasin, Managing Director, MSc Crewing Services and Chairman, CMMI. Captain Nitin Mukesh, Nautical Surveyor cum DDG Technical, Directorate General of Shipping. Dr. Ramesh Nair, Chief Medical Officer, Chief Seabird Medicare Center, Kochi. And last but not the least, our esteemed moderator, Captain S.M. Halvesa, CEO, Maritime Association of Ship Owners, Ship Managers and Agents, MASA. So for the panel members, just a quick request. You can see the timer here in front of you. So I hope that helps you match the time. And for the audiences, please keep posting your questions on the Slido app. Thank you.
Together. Good afternoon, and Captain Kamal Chadda, thank you very much. Happy to be here. As usual, you are wearing this with your usual panache and elan. I hope we live up to your arrangements. We have an eminent panel. And the topic for today's discussion is concern over PEME standards faced by the medical and manning sectors. Starting question, why have PEME at all? Well, it's required by law, STCW, ILO, MLC, RPS rules, etc. And primarily it is a risk mitigation exercise by the companies. Fitness for duty, STCW requires that you should be fit to undertake your job on board. Why do companies do it? Shipping is a business, and the outcome of every business has to be money. And this is essentially to save money. That's about a simple, basic bottom line to it. Handling of any illness or injury on board is extremely expensive. In 2017, there was a paper published in the Health Economic Review. And the paper was titled Cost of Repatriating an Ill Seafarer. So they did a survey and they identified only as a sample 4 areas. Acute myocardial infarction, the average cost they found was 98,823 euro. Malignant hypertension, 47,597 euro. Appendicitis, 58,639 euros. Malaria, 23,792 euros. I don't know how a measly appendicitis figured in the top 3, but it is there. And the cost here includes the cost of deviation, and which can be sometimes far way more than the actual cost of the treatment or illness itself. And the report says, repatriating an ill seafarer is a costly operation, and employers have a financial interest in promoting the health of seafarers by introducing or further strengthening cost-effective prevention programs and thereby reducing the number of repatriations. So it's a well-established fact. The people in the business here know that for sure, and many of us have spent quite sleepless nights, including the medical practitioners here, in trying to get a sick seafarer back safely at home. Captain Ramo, thank you very much for putting up the statistics. Even I referred to those statistics before I came here, and I did copy yours. Yes, 11% of the claims are for illness attributed to, but there was one slide in which it said that 11% of the claims between USD 5,000 to USD 3 million are attributed to crew illnesses, which is a shocking number. So, robust and a consistent PEME is a foregone conclusion. Yet, we have challenges. So, we have our eminent panel here, and I will now request each of the panelists to spend a couple of minutes in sharing their views on the topic on hand. So, would you like to start, Dr. Bilani?
Let Dr. Bharti
Okay. Okay. Opening bachelor, sir. He did that for you, not for me.
Good afternoon, gentlemen, ladies, guests. Thank you for inviting us. I'm going to talk on PME standards. So, the basis of the standards are very simple. IMO 1978 said that all seafarers need to have a valid certificate. Countries started making their own medical standards to standardize them, to make sure they are all on the same page. 1997 was when the conventions took place, got ratified, and we had international standards. Why do you need PME standards? Captain Halde just elaborated on this, so I'm not going to go through this. Just the last point, enhanced PME. By and large done by companies and by P&I clubs for the safety of the seafarers, to reduce claims, to make sure that they can work longer. So which PME standards do you follow? We follow in India Merchant Shipping Medical Examination Rules 2016 as amended. Then we also follow flag state medicals, P&I club medicals, company specific enhanced medical standards. All these are based on ILO guidelines on examination of medical seafarers. But please remember, there are variations between these groups, and that causes a lot of confusion. And it is very difficult to address. There are situations where he's unfit by company standards, but he is fit by flag state standards. What do? You can't issue two certificates. So what is the history? What is the history of medical PME standards? Started with Merchant Shipping Medical Examination Rules 1986. Then came the Merchant Shipping Medical Examination Rules 2000. Now here's the interesting part. Medical Examination Rules 2000 had Annexure A to G. Annexure A specified medical conditions which would be considered when deciding whether a seafarer is to be declared fit or not. I'll explain this a little further. In the meanwhile, in 2014, STCW Rules 2014 said that you have to follow Merchant Shipping Rules 2000 as well as use guidelines as issued by IMO. As far as I know, this is the only mention about IMO guidelines in Merchant Shipping Rules of India. Then came Notice 1 of 2015, which said the guidelines and letters on subject of medical examiner and of seafarers are hereby superseded by this MS notice. What that then meant was that all the previous notices were null and void. That is my understanding. Medical examination rules got amended in 2016. Now, here's the interesting part. Annexure A to G was replaced by Annexure 1, 2, 3, 4 and 5. They got substituted, that is the word used. My understanding, substituted, the old standards are not to be used, you've got to use the new standards. Again, interesting part, Annexure 1 said assessment of minimum entry level standards. It specified physical abilities of the seafarers. There was no mention of medical conditions. Annexure 2 was eyesight for beginners. Annexure 3 was minimum eyesight standards, which is there in STCW table A/1/9. 4 and 5 are the medical certificates. So for a pre-C medical examination, you're supposed to do annexure 1 and 2. And for periodic, you're supposed to do 1 and 3. Now, when you talk about annexure 1, look at this. I ask you, if there is a person who has uncontrolled diabetes, which of these functions can he not do? If you have someone who has undergone a coronary angioplasty, which of these conditions can he not do? In my opinion, he can do all these things. So, does that mean I declare him fit? It further goes to say that this table is not intended to address all possible chipboard conditions or potentially disqualifying medical conditions. So then my question is, what standards am I supposed to follow? And this is where the fight begins. The company, the seafarer, the relatives, everybody says, which standards are you following? Where is this mentioned? Are you using your own regulations? But the other clinic declared him fit for the same condition. And the last one is, see you in court. Yeah? One suggestion to all of you and to my DG Shipping. In the current standards, Annexure 2 mentions minimum eyesight that is required for a person to be declared fit. But nowhere does it mention that he needs to use glasses. Now, to me, this is a dangerous situation, because if you have somebody working in the catering department with a vision of 6 by 24 and 6 by 18, he can be declared fit. I think that's potentially very dangerous if he is not wearing visual aids. And the last point is Annexure 4. It's the medical certificate. It has no place for a candidate's signature. Now this is contrary to what ILO guidelines state. Thank you. This is my quote. I hope you read it. It's the state that we are in right now.
Thank you, Dr. Barfiwala. Thank you very much. You have already raised the major concerns, and I can see people fishing on their telephones, mobile phones, to ask the questions. So please be prepared. Would you, Dr. Nair, would you like to go next? Yeah, please.
I think it's on. Dr. Barfiwala has very comprehensively covered most of the problems which we face as medical examiners. So I don't have very much to add to it, except that we are always faced with this dilemma when a seafarer comes to us, and with these varying standards required by, like he said, the ship owners, the management, the management companies, and the various flag states. And can we, if we apply the strictest standards, because obviously it has to be the strictest, because he has to meet all the three, then you get into a bit of a trouble with the seafarer, because he creates a scene in the clinic, and he says that, if you do this, then there will be no need to go to sea. You go to apply such strict standards, and the problem will be faced mainly by Indian seafarers. So you are going to deny Indian seafarers from an opportunity to serve on board ships, and ships are not going to stop. The owners of shipping is going to continue. Somebody else will take the place with lower medical standards. And this is what he says. So sometimes it becomes very difficult to address these kind of issues. Many of them come with their families. And it's not easy to, especially for a person, sometimes they may have had a long layoff and they are, it's a livelihood for them. And it's not easy to say that no, you can't go because you're not meeting all the standards. So it is important that the standards have to be clearly laid down so that these kind of disputes and the kind of things don't come up. I am also a DGCA empaneled medical examiner. DGCA, it's all very clearly laid down by ICAR. And there is no differing standards from one country to the other. You can't have it because people fly from one nation to the other. And so it's very easy for a medical examiner to apply those standards. There are no arguments, no discussions and all that. And they know if something has been found and you may be temporarily on with for some period of time, grounded in case of pilots. But then you will be able to come back, or maybe you will be permanently unfit. And then in DGCA we have an appellate because we are doing medical examiners. The assessment is given by DGCA. They are the ones who give they have assessors over there, doctors. They are the ones who give the assessment, and they have so we have recourse to them. We can always tell them that it is this is what our findings are. You have any problem, we'll come to know. If there's any issue with the DGCA, if the assessors don't give an assessment, then you come back to us. In shipping, that is not available. This is the only additional thing which I have to say. The only thing is, you were mentioning visual standards of for seafarers, different standards for different people, because they do different trades. But when it comes to safety, it is important to have 6x6 vision. You can, with glasses, with contact lenses, like in aviation, pilots are allowed to have, you can have any power, 6x60. As long as it is corrected to 6x6, your binocular vision is normal, you are fit to fly. So there is no reason why you have to have the 6x24 as long as it is corrected. Thank you.
Thank you, Doctor, and thank you for the comparison briefly with the DGCA, because that seems to be a reasonable parallel to draw, since both DGCA or our DG for that matter, they deal with the international aspect of trade, maritime or aviation, whichever it is. May I request Captain Basim to say a few words? We will get a shipowner's perspective, because so far we have had the medical perspective.
Thank you, Captain Hardev. Actually, I am sandwiched with three people here, three of them doctors, one of them from the competent authority from DG Shipping, and moderators is supposed to know everything. So I am not a doctor, I am not a technical person, but I will speak my mind from the seafarer's point of view. Ensuring the medical wellness of a seafarer is a crucial thing for the maritime sector. Adding to that, it is equally important and responsibility of both, I repeat, both seafarer and the shipping company to ensure the wellness of a seafarer. It goes hand in hand. Companies might send many things, or from their supplier might send many steps, but the seafarer has to do it. And there come many factors how to comply with that. Seafarer, by the nature of his work, is exposed to varied conditions on the ships, depending on the type of ship, offshore sector, tankers, oil field ship, various. So they are subjected to a very difficult conditions. Then they are subjected to extreme weather conditions. Extreme cold, hypothermia. Extreme hot, hyperthermia. And add to that, they are working for a long period of time away from the family and home. All these things set in many factors. Dr. Anil Deshmukh spoke briefly about one case study he was giving. The person get anger, anxiety and other things. What does happen? You are away. So you are supposed to, companies are supposed to have welfare feature for their own seafarers. When you call them their family, Just the way you look after your own family, same thing you have to do there. That is my take. I am also sure, of course, the doctor spoke about some medical things. They spoke about parameters, different tests. Well, let's say that is done. Let me add to that to respective doctors. A good company not only do test as per the ILO or IMO only, or as per DG. They are do much more than what is minimum required. Most of us present here are doing that. So that is what is that known as not a compliance, that is known as competence or doing something better for the seafarer. But once that is done, then actual job of a seafarer and shipping company starts. The medical is done, you have got the certificate. What about the health monitoring on the ship? What about the mental wellness facilities or counseling facilities given to the seafarer or their families while on board ship? What about the baby steps like yoga? DG sir spoke about Sagar Mein Yoga. We have been doing this for a long time on board our ships. Yoga, light exercise, breathing exercise, drinking water. Don't drink water. They say eat water. These are the steps that you should always emphasize on board ship. But not only send one time and then keep quiet. Responsible companies should also, like a human being, you need to remind the seafarer that do this thing or take a report. Have you done it? It's not only a technical job. It is a very, very comprehensive, well-being job, responsibility of both seafarer and the shipping company. That is my take on this. As we go along, we speak more on this. Thank you.
I'm physically fit. I can keep going up and up. Thank you. Before we come to Captain Mukesh, since he is from the government, I know I referred to you as the wicket keeper because everything will come to you at the end. You have to defend. So, may I request Dr. Belani to say a few words?
Good evening, everybody. Captain Chadha, I am aware of the privilege you have given me to be present on the dais and express some of my views on the difficulties dignitaries on and off the dais. Thank you very much. Dr. Barfiwala, Dr. Nair, Captain Bhasin have said much and it made my job easier. And we can then skip some of the slides here. Dr. Barfiwala has spoken about the legislation. I am going to say what difficulties I face on a day-to-day basis with our seafarers and medical examination that we have. Ours is a policeman's job. I am here, that's what the seafarer says, find what is wrong with me. I shall not give you my honest self-declaration on health. So that's the difference between the medical examinations we do in our clinic. When we have corporate clients, when we have patients, they come up with a very honest declaration, come up with all their complaints because they want it sorted, preventive health, prevention better than cure, nip it in the bud. But not the case with seafarers. It's a lucrative job, we understand that, but what about the rigors of seafaring? It's a very, very tough job at sea. Honest self-declaration, Captain Deshmukh has spoken about it. Everybody knows that we want an honest self-declaration. This is the basis of a medical examination that we go on. Objectives of the PEMI, very clear for all doctors. We want to reduce the value of true illness and claims and exclude all pre-existing illnesses if we can screen them. But without a honest self-declaration, it becomes such a challenge. And we know the risk of unhealthy crew on board. Gone are the days when one crew member, if he were unwell, the burden and the responsibility could have been taken by the others of the 53, 54 or maybe 60 crew complement on board. Not now, 22, 23. The distribution of burden and load of work is tremendous. And with technology, automation, leave one port in European waters and you are ready to arrive at the next. Unified code of PEMI globally. Is that a dream? Well, I don't know. Quality versus cost. Well, Captain Deshmukh made it easier for me. He's already given a graph. Spend a little more and save so much more in millions of dollars. Dr. Parfiwala has spoken about this, so we'll just skip all these. We've had eye disorders. We have so many challenges on a daily basis. The visual standards are not very clear. Already spoken about. Body mass index. Somebody in the morning itself in our clinic said, I'm just 2 points over the upper limit. There is no upper limit. Unfortunately, there is no upper limit which is defined in body mass index. But I told him visually you are obese. On the weighing scale with your height, you do not meet the WHO standards. Our PEMI standards do not define any BMI guidelines, whether they are borrowed from WHO or otherwise. So again, it's the same thing as Dr. Parfiwala said. Which of the standards do I follow? Diabetes mellitus, already spoken, and heart disease, this is demographic. Most of the PNI clubs have now introduced standards which are country specific. Ukraine, Philippines and India I know about. I don't know if there are any other regions that the PNI clubs are doing. So this is what it is. Heart disease hits Indians early. Diabetes, high blood pressure make it worse. And some of the PNI clubs won't take seafarers with coexisting blood pressure and diabetes. It's an alarming fact, diabetes. So again, standards do not define our upper limit of glycosylated hemoglobin, where I should say that's it. We know the good standard, what we should allow, but how to define this to a seafarer? How to answer his and address his questions? 90% of the diabetics are not aware of the condition. Because in my experience, most of the Indians, if they don't have fever or pain, they are healthy. So hypertension, diabetes, and certainly of these silent diseases are of no concern to them. Cardiac events, another big challenge for us. When one has a cardiac event, how to declare him or her fit post-recovery, post-rehabilitation. So there are certain recommended dispensation, suggested dispensation items which Captain Mukesh has already said they are working on. So we hope it will come to us very soon. Malignant disorders, ILO is very clear, 5-year surveillance. But there are certain tumors which can be excised so precisely, and doctors, oncologists say it's a complete cure. We don't know how to deal with this. Should I deny a seafarer his livelihood? Joint replacement, another grey area. Within the ILO there are conflicts. The ICD codes are conflicting right here. I hope our regulator and Captain Mukesh, wicketkeeper, will take care of this. Gallbladder stones, they say if you have no history of colic pain for 6 months preceding the medical, the candidate may be declared fit. We have not had any candidate who has said he or she's had gallbladder colic in spite of having stones which are discovered on the ultrasound. So there is a conflict of interest we face on a day-to-day basis. There are additional tests that we want to do and must do, because demographically Indians are different, and within the country we are a big, huge nation, almost a continent. So north to south, east to west, we have very unique diseases and the demographic patterns that we see. And medical technology has made giant leaps in the years since I was an undergraduate. Case study, cataract surgery. A person with cataract surgery when I was an undergraduate was confined and relegated to bed for 4 weeks. Today you leave the ophthalmologist's office in 20 minutes after surgery and watching TV in 48 hours. So we can consider this. This has already been said, limited availability of medicines in the medical chest. When it comes to radiomedical advice, we really have a lot of challenges. But yes, hopefully this would also be revised soon. Thank you.
Thank you very much, Doctor. You have certainly brought up certain pertinent points. And now we come to our regulator, Captain Mukesh.
Yeah, good evening everyone. I was hearing so many people and they have pointed out a lot of discrepancy in our rules, just like medical examination rule 2000 and 2016. But prior to that, I was wondering that why there is a concern about DME. There is a guidelines, MS rules 2000 and amended by 2016. Also there is a STCW, there is MLC. There are so many guidelines have been provided, and no one can tell that which all tests to be performed to which seafarers. This has to be decided by the doctors, that when that seafarer is fit or unfit. If we see the medical examination rule 2000, it is clearly written there that there is a pre-C and the periodical test. And the pre-C, it has been mentioned that some test it has been mentioned, and it has been given to the doctors that when that seafarer is fit or not fit. And as a seafarer, when I was going for the medical, I was thinking that I am a footballer, like a football. Why? When you go to the doctor, one doctor, company gives you that, okay, go and perform that test. They will give you the address somewhere in Mumbai. We go to Mumbai somewhere. Then that doctor will tell, okay, for a year you go there. We are searching. Then for something else, go there. So for full day we are wandering around where to go, that. And as a seafarer, I was feeling pity on myself that what I am doing. Why it is happening like that? So the doctors should also think that when they are performing the medical test to the seafarer, the proper respect to be given to the seafarer. And they should also feel that they are a part of the maritime fraternity, and whatever AB or captain, whoever it is. And the concern shown here regarding the PME, that there are so many guidelines, go through that. There are MS Rule 2000, 2016 for pre-C and the post-C, which all tests to be provided, and declared fit or unfit, whatever it may be. Before coming here, my friend came to know that, I will tell you one this thing, my friend came to know that I am coming here. I want to point out one thing, that he told me to ask from the doctor, that suppose somebody is having angioplasty in the heart. I think so, I don't know, I do not know the rules. They told that they cannot go in the foreign vessels, but they can go on the coastal vessel. I don't know how much it is correct. So why there is a discrepancy? The coastal vessel, the same person can go, but the foreign going they cannot go with having angioplasty. So there is, and when I was going through the reports, that the DG sir has also told that there were so many casualty and all. So what I found out, there was no uniformity in the reports, in the medical facility, in the medical practitioner report. There was no uniformity. Somebody was doing some test, and maybe that manning sector was telling that to do that, to do all this type of test. Person is declared unfit here in one of the facility. They get the declared fit at another facility. I don't know how it is happening. There should be the standardization of the report. If the standardization is not happened, so there is no point telling that, bringing the rules that you do this HbA1c, SG, some test, the full test. We cannot tell like that. It is the doctor responsibility to declare that seafarer is fit or unfit, depending on their experience, depending on their guidelines. Then they can send you to them on board vessels. And for the manning sector, I can tell that there are 1,023 doctors are approved in India. 1,023 doctors all over India. Mostly are in Mumbai region, and there are discrepancies in the regions. In some part of the place there are no doctors, so it is difficult for the manning sector, the cost wise. The cost implication is also there. If you tell the seafarer to come to Mumbai, the cost goes to the manning sector. That this has also to be looked. If you describe the test also, that also requires the money that is for the manning sector. So the doctor should also think, we cannot prescribe the test, and that company has to pay. So I wanted to also tell that we are in the process of revising this medical examination rule 2000 and 2016. So we are coming with the full setup. Means after 1 or 2 months we will be giving to the stakeholders to give their comments. So accordingly, whatever the comments that Barfiwala has given, that signature is required and all these things is required, they can come up with that. So I don't think there should be concern that MLCs, there are a lot of rules, medical examination rules. Follow that and declare that seafarer is fit or unfit. There are two things only: unfit for 1 month or unfit for lifetime, whatever it may be. But think that seafarer is also a part of that. Do not think that, do not play like a football. Go here and there, here and there, here and there. Do it at one place. So that's why you have seen that that new circular, which you have taken out. I think none of the doctors liked it. 8 of 2023.
That is about having all in-house facility.
Yes, in-house facility.
And following the NABC
NABL, NBCS, that all this. I don't think any doctors liked it, that circular. But as Sir has told, DGCA guidelines, I think that they are following that NABL guidelines.
So, may I do it? I am also a DGCA approved doctor. DGCA has no deadline for a prospective pilot to get on board, whereas a manning agent has a deadline. You refer a blood sample to an NABL accredited lab, let's say Metropolis. All their labs are not NABL. The central lab is NABL. So collection in Navi Mumbai must come to Worli. They will not be able to give us results in time. And over years, as you said, that you were asked to go here and there, things have changed, and you should visit something. Most of the clinics have the usual tests under one roof. All tests are done under one roof, which is usual. Specialized tests may be outsourced. So that's a convenience that seafarers enjoy now, that all tests are done under one roof. But DGCA, we cannot, yes, they are NABL. But NABL accreditation is a very tough accreditation. One of my labs is NABL. And the same ISO standard is adopted by ACAB, ISO 15189. So why only NABL? You can have 15189, same ISO standard, by a different certification body, which is much easier because NABL has a tremendous emphasis on hierarchy, lot of documentation. If this doctor is not available, then who will report, cannot do this, cannot do that. In a shipping setting, this will probably not be very practical. We should take a holistic review, but I'm glad that you are revising the guidelines and sending to all stakeholders and inviting their viewpoint and their suggestions and being inclusive. It will probably come out well. So this is what I wanted to just say, that DGC has no deadline. If I examine a candidate today and I submit to the DGCA office 3 days later or 4 days is acceptable. They may at times take up to 4 weeks to give a final dispensation. And there were a full team of very highly qualified doctors in aviation medicine, and they take the final call, whatever we do. Because we have to take a call, and we must do it within a very limited time.
Yeah, that is right, sir. Because prior to this circular, there was no time. I'm not talking about the time frame. There was no standard. Anybody was going anywhere and doing it. And I will tell you, I was posted in MMD also. I was getting medical certificate in 100 rupees. I don't know how much from where they were getting.
That's too much. That's too much. Thank you very much, Captain Mukesh. Thank you. Yes, you have certainly raised some pertinent points. But coming back to the point about the medical certificate, I took the trouble of actually downloading all this, going through all that. So I'll point out to you one. The old medical certificate actually had an undertaking by the seafarer that I have declared everything truthfully. The new one doesn't have that, which is a bit of a concern. There is, okay. The new one is the 2016.
So I think so there are 4 or 5 distinct forms. The front forms, the first forms require the seafarer signature. That which is need to be submitted, that 4 or 5, third or fourth form, that does not require any signature. The front form which is submitted to the doctor, it requires a signature of the seafarers. It is their signature, seafarer signature is there. That is which is submitted to the. We think that if you sign the first form, it is taken care of all the forms. 1, 2, 3, 4. If you require in all the form signature, then we bring that. We'll bring that. Because one seafarer requires all forms. 1, 2, 3, 4, 5. I think so. And the first form is signed by the seafarer. Declarations, where the declaration is there. I do not have this problem. I do not have this problem. The front form. That is a concise form is there. That first form.
So what has happened, as Dr. Barfiwala rightly pointed out, there is a statement here that annexure A to E are now removed and replaced by these annexures 1, 2, 3, 4. That's what the notice says. MS Note, the Gazette notification says. And the Gazette notification doesn't have that page 1, 2, 3, 4. It has only got this page which has no signature. So the point is this needs to be sorted out, because as Dr. Barfiwala rightly pointed out, there is a court, and before the court there is the DG, and rightly DG takes a pretty dim view of this, and rightly we need to protect the seafarer for sure, for no doubt about it. But doctor, I have a question. And so is the question for the shipowner. See, the seafarer's earning bread depends on him being fit and going on board. So, do we really believe that he will tell truthfully exactly what is wrong with him? Do we really believe that? Are we so naive? How is it possible? It's not possible. I think so. I wouldn't have told.
So are we the villains?
No. No.
So where is the median line?
That's a question.
That's a question.
Mike.
So in my view, all seafarers are nomadic. They work for a company for a certain length of time, then they shift, by and large. It's not always true, but this is very often seen. So if I have done his medicals over 2 years or 3 years, I have access to his data. But once he shifts and he goes to Dr. Milan, he goes to Dr. Matthew, he goes to some other doctor, they are not privy to the information I have. And I cannot share it with them. The problem comes when a person has signed off. I know he signed off for this reason, but I can't share it. And he as a doctor is not aware of this. Typical, we are talking about mental health issues. Mental health issues, you should discuss it. If you are under treatment, if you are not under treatment. As a doctor, believe you me, there is no way for me to find out that a person is having mental health issues if he is well controlled with medication. How do I check whether he is on medication unless he declares it? So ultimately somewhere something has to happen whereby we can share at least the sign of information. Whether you need to take signature or you have to follow GDPR rules. I do not know how it should be done, but something needs to be done.
Yes,
You
sir.
want to protect the seafarer. You want to make sure that I'm not talking about claims, I'm not talking about the company. To me, primarily the seafarer is important. So if the seafarer is important, how are you going to do this?
Sir, I'll stop you here for a minute. It's not just the seafarer who's important. It's his colleagues on board. It's the ship, the cargo, the asset, the environment, everything is important. So we shouldn't, I mean, the seafarer is part of the whole system.
So, sir, when you talk about calculating risk, supposing a person has a condition, how do you calculate risk? Risk is equal to likelihood with consequences. The consequences can be to the seafarer, to his colleagues, to the company and to the vessel. So you then have to individualize it, so it becomes a little task.
It's not easy.
It's not easy.
That's why it's an examination. Otherwise it would be an examination. Captain Mukesh, one thought occurred to me. Yes, he has Dr. Barfiwala and Dr.
Yes.
Belani.
Yes, I was saying that I don't know that legal implication. I have to check that. Why not we maintain this EHR, electronic health record?
I was about to ask you that question.
Yeah.
That now with the DG Shipping launching on a very big e-governance project and etc. The doctors, the RPS companies, all of them are on that platform even today. So if there is a threatening condition, as Dr. Barfiwala pointed out, they're signed off on mental health or signed off with some other physical condition which is also detrimental. If the doctor reports it in that place, which it needs to be worked. We are just discussing.
I don't know how much it is correct. When we were selling that, people were saying, I don't know, that Manning company, suppose I am working in MERS. I left the MERS and joined some other company. That we were in that this company will ask from MERS that how was my performance? Why I am leaving?
What they would ask?
How is my performance? Performance. So why not that the Manning company or owners should maintain this electronic health record or digitization of the record so that they can access the record in between that what is that between this and I don't know legal implication. Legal implication I do not know. That has to be
I have another question. One second. I have one more question. The legal implications, of course, they are serious.
Yes.
But instead of sharing, but what happens? What prevents the DG Shipping from maintaining that record? Because they are already uploading some pre-medical into the DG Shipping website. So if somebody has signed off on
medical which is being uploaded, that is fit or unfit,
pardon?
not the full report. Fit or unfit.
Even if it is fit or unfit, the person has gone on the ship. Suppose he has signed off with like the Filipino seafarer which Captain Amol showed. Okay? It is a serious matter what has happened. Now, that seafarer, the way he has signed off, let's assume, since Dr. Belani is here, if he could upload it on that INDOS number to inform DG that there is a problem here. It doesn't mean anybody else has access. You have access, the seafarer has access.
In that case, what Barfiwala has told, that suppose that record is uploaded on the DG Shipping site, I agreed, uploaded. But if suppose from the Barfiwala he goes to Dr. Belani, how the Dr. Belani will access that report?
Sir, I'll be your consultant. Will you pay me? No, this needs more discussion. But I think, and when we started and I saw 75 written here, I thought, kya karega 1.5 ghanta, sawa ghanta. There's hardly any time left actually. So if we will take some questions, if the audience has some questions. There's a question. Non-declaration of existing disease, if not paid compensation and treatment, what experience clubs have? I don't know who has asked this question, but if the way I understand it, I think it refers to the standard A 4 point something which Captain Amol presented, that in the event it is not disclosed, then the liability is not on the company, it is on the seafarer. But according to the present regime and rules, it is RPS's responsibility and owner's responsibility to repatriate it. That does remain. So there is no escaping that part of the liability. Compensation you may not have to pay. That's a separate issue. And if you want to recover your expenses, you can go to court and recover and hope for the best, if it works ever. So there is no way that there will not be any financial liability or a cost involved.
Actually, irrespective the person declares or not declares about his previous medical history, if while working on board, he undergoes into the medical condition which was pre-existing, therefore I understand from the question. Still, it is the responsibility of the company to treat him and bring him back home. It is the responsibility of the ship owner, the RPSL agent, or the shipping company. That thing is not taken away, irrespective if he declares or not. Just to clarify. Now comes the point of the compensation. That is then with the PNI matter. But the first thing, the first medical care, welfare remains the responsibility of the company. Yes, sir.
On medical grounds, or you have a clean sign off? If you have a medical ground, it should be there. So the next company at least knows that he's got off on medical grounds. Right now what we are doing is, I'll tell you about MTM, I can't speak about the other companies. It is a clear-cut instruction from me that anybody signed off is rejoining, and if he signed off on medical grounds, he cannot be concurred unless I clear him. Irrespective. So then what I do is I basically go into the history. How many times did he signed off? We have got cases we have found in our own company, guys whose job is to go on the vessel and get off on medical grounds. Professionally. There are. So what is happening is, MLC, my crewing head tells me, sir, you can't do this. I said, throw the bugger out. You can't do it. Obviously, you can't do it. So what we do? Damad. We bring him home, we give him 1 month medical treatment. It's found out that he's got some kidney problems. So we treat him. So hence, the only way out of this, what I realize in my small senses that I have, that anybody who is rejoining has signed off on medical grounds cannot be approved by anybody in my office. I need to see his reports. And then we take it. I have cancelled a couple of people's joining because out of the 4 contracts, 2 contracts he signed off on medical grounds. I can't take a chance with them. Because of PNI cases. And
No, it is a-
doctor, we have to go to give them salaries, standard wages.
It is a major challenge.
It is a
Most,
challenge.
lot of us have different experiences which are along the similar lines. Captain Matthew wants to ask. But Captain Fadnis, I must say here that you made one remark which I don't know if others heard, but I heard it. You said we treat him like a damad. What do you mean? What is this supposed to mean? I know what you mean. You are from Calcutta. I know exactly what you mean.
We wanted an AB in Goa. My crewing guys did not have an AB to put on board. So obviously, as things go, he एक AB नहीं दे सकता है. So they got one AB from Gujarat. How can he reach Goa? Cannot. So we said, get the medical done there. He joined on board. The minute the ship sailed that evening, he started walking the alleyway. It was a mental case. So we had to treat him. He was treated like a damar so that he can't go and injure himself. Because rightly said, he is our responsibility.
Yeah, absolutely. You put him on board. No
I
question.
had to put one guy on constant vigilance till the time the vessel reached Guiara, got him off, and we wanted to sign off a cadet. Along with
Yes,
the
Scott.
spotter, that he
Sure.
not himself. So the ship
Sure.
will say, or authority will say, your responsibility.
Yeah. Captain
That's
Philip.
the word, the man.
Yeah. I know what you meant. Captain Philip.
Sir, good evening. I have just a couple of queries. One is I want to know, like, there will be very few medical cases which cannot be found out when a person comes for a medical examination, maybe schizophrenia, maybe some mental illness. But can you name which are these illnesses which cannot be detected in a thorough medical examination?
Captain Matthew and the August gathering, we can mask diabetes, we can mask hypertension, we can mask asthma. These are the most common things. We had a case this morning, young man taken up, we just saw him in the gallery of our office, taking a bronchodilator before coming in. Thankfully, our Dr. Firoz saw him and said, what is this? Oh, he said, I came up the steps, so I was a little breathless. But why do you have a pump in your pocket? I don't have. So these are the 3 most common things.
Thank you. One more thing, I'm very happy that Captain Nitin Mukesh said that they are revamping the whole MS medical rules 2000 amended by 2016. I would think that in this process, the whole set of a good set of our doctors are also involved, so that we can, I have come across PEMD medical tests passed, declared by top doctors, I don't want to name anybody, having bilateral kidney renal stones. I have come across many things which I don't want to explain. See, we need to have the guts to withstand pressures. Either from ship owner side, I am not saying ship owners are all saints. We are under pressure to man our ships. We tell you, chalo 2 mahine ka fitness de do, 3 mahine ka fitness de do. We should resist all these things. We should take up this. It is not that seafarers are themselves to blame. Second thing is, the seafarers should be educated. Can we educate the seafarers? Can we conduct sessions for them? Because seafarers' health is very important to their family. More than my company, I am concerned about their family. Their life lost at sea matters more for their family than the company. Company wants to run their ships. I think we must have our attention drawn towards this also. Thank you so much.
Captain Matthew, I cannot agree with you more than what you said, but we should have very specific guidelines. As Dr. Nair said, DGC has very specific guidelines. Eyesight so and so, cataract surgery, so many weeks of post-operative rehab. Knee replacement, gallbladder, cannot fly, cannot do that. So why would a ship owner or a manning agent pressurize a doctor? They should also realize that this is not in their interest, one. Number two, yes, it's so important to educate, counsel the seafarers, that they must, one, understand it is so important. When at sea, they have access to very, very limited resource of medication, healthcare and medical advice. Thanks.
Captain Matthew, when you asked the question, I wanted to stop you before you said second question, because at the end of your first question, 2 doctors ran for the mic, you know. So you should have given a chance to them.
Thank you. I thought you were stopping me from asking.
One thing, I want to tell Captain Matthew sir that you told me to call the doctors for the rules, but be ready that when we met at one party, you told that what circular you have taken out regarding transgender. I cannot understand. That is in consultation with the doctor only. We called all the doctor and we discussed and we took out the circular for transgender. That what should be the applicability rules and regulations. So we are going to call the doctor, but be ready for the language that which people are going to understand or not.
We will have to live through that, sir. We will certainly have to. But I have a question now. All of you are medical practitioners. When I say medical practitioners, who undertake or who conduct PEME. Now, you will see certain commonality in the pre-employment medical examination that you do. That over the last 20 years, maybe you have found that the incidents of high blood pressure are more, incidents of maybe lower back pain are more, or something, or maybe incidents of sign-off because of any specific reason are more. Is there any method for you to give a feedback to the administration to include that, or do we wait for the P&I clerk to issue a guideline and say Indian seafarers, you must undertake this so-and-so test or whatever it is? Okay, Dr. Karfiwala.
So what normally happens is most of our clinics, we have statistics collected at the end of the year, and we try and share it with companies that this is the trend that we are seeing. Whether you want to work on this or not is up to you, but there is no way that we can contact the administration and say this is the trend we are seeing, at least not in my experience.
We have very limited access to the regulators.
No, you can communicate. But Captain Chadha, for your next conference, you need these statistics. One session where the doctors can come together and put up the horrifying news on the screen.
Captain, always difficult to even compile statistics. Dr. Karfiwala said a particular set of seafarers coming to be in Mumbai from North India or East India. When they sign off, they go back to their hometowns.
Right.
So the manning agents or the ship owners must provide doctors with the statistics, and we can compile and find them and submit.
The problem is that, supposing I'm working for a company that company is working with me in Bombay, but they have offices all over India. So if they tell me that, look, so many people signed off for this reason, then it becomes easy for me to go back and look at my data and try and collate it. But it never happens. In my experience, companies are very reluctant to share sign-off data with the doctor. For what reason, I do not understand. Same happens with PMI clubs. They put up their data, but if you ask them, give me specific data to my country, again the reluctance. So, why data like this? I am not naming anybody. I am not saying X person came to me or Y person came to me. I am saying, okay, these many people came, this is from the agent side, this is from the tech side. It helps, but you don't get this data.
Sure, I agree. It will help to close the loop. And you are looking only for illness. You are not looking for injury, because injury is something that happens on board and it's an activity related issue.
I think, sir, in this case, association will be very useful because they are having access of this all the company, so they can share with the regulator.
So ये काम करते करते मुश्किल हो रहा है मुझे आप association भी बीच में डालते हो. We have okay. Captain Tandon, yes, please.
After you. Thank you. Well.
Yes, it's on.
There is a few things which you can constantly look at the sea, you can constantly look at the fire, you can constantly discuss the payment. Because fortunately or unfortunately, we will never really find the really, golden standard when nobody will die or get sick at sea. There is some countries who's doing it better, some countries who's doing it worse. Of course, we have to think about our seafarer, and what was really mentioned, very important, it's about the family, because sometimes through the family you can approach the seafarer. I'm calling wife sometimes, telling your husband is sick, and if he will not follow the rules, he will be dead, and you will not have any income. The scene is really changing, in this case. We really approach the time when the international standards should be changed, and we have to produce a new book, the standards of the medical examination. It's a lot of issues about vision, about the color vision, and about the other standards. It should be for sure mentioned the possibility of appealing, because let's be frank, some doctors don't like the seafarer or he finds something wrong. So it should be mentioned that there is a way to appeal and to ask a second opinion. But this is also should be mentioned. So there is so many things to discuss, and I think it should be discussed not within, only the countries. We should sit all together, the working group should be done like, Spain have a perfect system when they put all the data inside, the common computer line, so every other doctor sees the results of the previous examination. It's done on the governmental level. But very often when we're talking about the digital passports and so, the main problem was who will keep the data. Like in Russia, it's not allowed to have the data of the Russian citizens live anywhere else than in Russia. So if you work for another company, how to deal with this? So I think we have to think all about these small things. I really welcome, for example, for the diabetes, we established these international groups because we think that the urine test or just the glucose test is definitely not enough. And we see a lot of, undiagnosed cases. And these lead in the future, for the cardiac effects, etc., etc. So it's a lot of work to do, and I really hope that we're not afraid to talk about this, and we're discussing, because these type of meetings where the doctor meets another specialty and the industry, are very important. We hear you and you hear us, and then we will find some way in the corner.
Thank you, ma'am. Dr. Mukesh, when the doctor was saying something, one thought went through my mind. As an administration, you are dealing with the PNI clubs. You have a contact, direct contact with the PNI clubs. For some other reason, but you have one. Would it not be a case to ask the PNI clubs for this medical data, not by name, but pertaining to illnesses for Indian seafarers, because IG has only 11 clubs, right? Or 13, sorry. IG has only 13 clubs. You ask them for the data, and maybe it will help you with the doctors to formulate something more robust so that repatriation of Indian seafarers doesn't happen. Mind you, repatriation on medical grounds is a business killer. We have seen companies lose business, employment opportunities because of this. That has happened. On the larger companies, you may not see the numbers, so the smaller ones you can see because the impact is immediate. We had Captain Mehta wanted, or Captain Tandon wanted.
Yeah, thank you. I just go back to the self-declaration of health conditions, and Shiv, you attended the ITF-IBF negotiations this time, and there is a clause when duty of care requires, I'm going to put you on the spot there. The clause actually, we face so many cases where people misdeclare or they hide their conditions, and when they come back as a compensation case, when we have, our members have approached the administration, they said, well, it's your doctor's job to have found out that he had this condition. Now, in this particular context, there was a clause which said in the pre-employment medical, historically it stated, failure to declare may affect the seafarer's entitlement to compensation as per article so-and-so, so-and-so. At the behest of the PNI clubs, this year, this clause has been changed to will affect the seafarer's entitlement. Yes. Can you please elaborate on that for benefit of others? Because it's a commercial contract that we are entering into, and an amount of duty of care has been put on the seafarers to make sure that he declares correctly, because if he is not declared, he will not be entitled to any compensation or benefits other than the repatriation and immediate treatment. Can you please throw some light on that, please? Thank you.
Thank you, Rajesh, for pointing that out. Actually, Captain Amol, in his presentation, the last line, he actually showed that even the MLC in clause A 4 point something 5.2 or something like that, it states that the liability will cease or will not be there for cases where there is a misdeclaration by the seafarer or wrong declaration by the seafarer. And the CBA that you mentioned actually reinforces that. Instead of may, it has become will. I presume one day it will become shall also. Because it is extremely expensive. And mind you, any of these repatriations, whether you pay compensation or not, you still be out of your pocket by $50,000, $60,000, $100,000. That will happen, and there is no recourse to that amount. Thank you. I had, as I mentioned in the beginning, I had thought that what will we do for 75 minutes? But we have only 5 minutes left. So, okay. Question? Yes, please. You have Captain Sehgal. Yes. I was about to say 1 minute to mic आगे पीछे में चला गया.
Good evening, everyone. I'm Sanjeev Sehgal. It's an interesting topic because I am an ILO's trainer on the Maritime Labour Convention. And a lot of what we are discussing today, I think 10 years back I have been propagating within the industry. And I see here Dr. Bharjiwala, which takes me back more than 20 years back when I sat with Dr. Ranbir Singh and did a wrong analysis of the French. Okay, now the question that I want to actually not ask but more or less answer from an ILO perspective, because that's how we've been propagating. What was mentioned was that there is a confusion on what we should follow. There are so many different guidelines, rules, etc. What should we follow? The stand has always been that what IMO and ILO have given is the minimum standard. Okay, it is now left to the administrations to choose what they want to do with that, what else they want to add. So, from a doctor perspective, you need a guidance.
For an Indian flagship, the DG's guidance will determine what should be the minimum standard. Then comes the company. The company can put anything additional. This is very much similar to what we do in the CBA. You have a minimum requirement in the MLC, you can add anything more in the CBA, and that becomes binding. So if the company gives you a standard, that is to be followed. So in my opinion, when we make a statement saying that there is confusion, I feel that there should not actually be a confusion, and my request to the administration here is that you should be the one who should decide that since we are talking about Indian seafarers, we have sufficient data on Indian seafarers, we should be able to identify what are the exact tests that we would like to do for Indian seafarers, because not only for Indian seafarers on Indian ships, we must understand that whatever tests we do, world over there are a number of flags which are relying on those tests to make sure that the Indian seafarer on their ship is very good.
Thank you, Captain Saigal. When you were saying this, I actually opened up the amendments 2016 and I'm going to read out to you the first line. These are like the table of competencies in SVCW. There are 3 tables here. Shipboard task or function, event or condition. 1. Routine movement around the vessel on moving deck between levels and between compartments. That's a function. Relative physical ability, maintain balance and move with agility, climb up and down vertical ladders and stairways, step over coamings, etc. Okay. Medical examiner should be satisfied that the candidate has no disturbance in sense of balance, does not have any impairment or disease that prevents relevant movements and physical activities, is without assistance able to climb vertical ladders. Show me a medical clinic in Mumbai where you have very vertical ladders to climb for the seafarers. So when these standards are laid down, it is now the confusion starts. I think so. At least I am totally confused right now. How are you going to establish that? And we have another issue. Our standards are captain to cadet to cook are the same standard, but they do entirely different things. So shouldn't the standards be different for different positions? A question for you, doctor. We have only 1 minute.
The standard should actually be different.
Even the mic is tired, you know.
Ideally, the standard should be different. There is no 2 ways about it. If you have somebody who comes to you and you do all these things, but these are physical abilities, I am asking you about medical conditions. One is the physical aspect, can he climb up and down? The other part is, does he have diabetes? Has he had angioplasty? As a practicing seafaring doctor, what guidelines do I follow? Because merchant shipping says follow guidelines, annexure annexure 1 to 5. Yeah. So, but it does not mention anywhere that I can refer to ILO guidelines. Now the problem is that when you declare somebody with uncontrolled diabetes that look, you need to sort this out before you go, he says, show me where it is written. And what answer do I give? Put yourself in a doctor's shoes. How do I answer a question like this? If I tell him, he said, look, where is it written? You are an Indian, you have to follow merchant shipping. Medical examination, where is it written? How you can access it? Any seafarer can access it. And if he can access this and he's smart, he's going to ask you this question and you have no answer to give. That's where the fight actually begins.
Yeah.
There is answer in the medical examination rule 2000 and 2016. Answer is there. Doctor, the practitioners to decide the seafarer is fit or not. So they are the best person to decide they are fit or unfit. So that is written in the medical examination rule 2000.
No, even here.
Yeah, it is written.
It is there.
Doctor should
Well, it
decide.
says that doctor's judgment prevails, but that also opens the Pandora's box to go to the court.
And one more thing I want to tell, in every prescription it is written that there is no liability on the doctors. There is no liability on the doctors. Any test. If I go for the test, it is written there down below.
Can I answer that? I am not the doctor. Sir, 2-3 हजार रुपया का टेस्ट करवाते हो, क्या liability लेगा डॉक्टर? उससे ज़्यादा तो नहीं लेगा वो. Yes, Captain Rajvanshi. We are over the limit. Now it is a red light. इस सवाल 1 मिनट का होता है, जवाब का प्रॉब्लम है.
So this same thing was shared by Captain Mukesh also. I also need some clarity on angioplasty. Somebody is having angioplasty or some seafarer has gone for his transplant, heart transplant. Can we send him on board? I had a case, in fact a lot of cases, where a seafarer came to me, he said, I've been working in a company for the last 23 or 24 years. And then I had to undergo angioplasty, that seafarer. He said, now that company is saying I can't send you back on board. I said, okay, well, I'll send you with my doctor, and then as per the doctor's advice, we will see what to do. And as per the doctor's advice, finally I managed to send him on board. So is there any clarity about such cases? Because I think it's still a big ambiguity, or again depends on the company and the doctor.
In MS rules is very clearly written, and coronary angioplasty, coronary bypass grafting is not fit for C service.
Old one.
So what is applicable? I don't also say the same. Worldwide it is functional.
See, can you, Captain Anshul, you asked the question and I told you answer is the problem. I told you. It's already 2 minutes over. And there is a debate now among the doctors.
There's a last one. Actually, Captain Mukesh has said correctly. There is no ambiguity at all. Everything is laid out in the Medical Examination Rules 2000 and the MLC 2006, which was amended and then brought into in 2016. Everything is very, very clear. Every segment of these questions are answered, and it's very clearly said that if you had a myocardial infarction, if you had an angioplasty or a bypass, you are permanently unfit for sea service worldwide shipping. However, in limited waters, you may be allowed. It's very, very clear. It's already there in the rules, so I don't know where the ambiguity at all.
So there is ambiguity because you need to read the amendment. The amendment of 2016 cancels, so you read. If you don't read, what can I say?
Doctor, delete that last one. We are 3 minutes over the time. That line is deleted.
Sir, I'm just taking this example forward. This particular example of coronary angioplasty CABG. This is actually taught during the refresher course by a DG Shipping approved institute.
No, taught what? How to have one?
So when we mention, when we are doing the refresher course, this is one of the examples that is specifically taught in cardiac conditions. That CABG, coronary angioplasty, permanently unfit. Only exception is near coastal vessels, because emergency evacuation is possible.
Access to medical care is possible.
Yes, yeah. So my point is we have stalwarts of the field sitting over here from the medical field. We have regulators sitting over here. We've been discussing this issue for last 15 minutes, but we are unable to come to a conclusion. That is the point of a guideline. My point is this: we are operating in a vacuum. We are in an ecosystem where we have a regulator, we have shipping industry owners, we have doctors. We need clear-cut rules, we need clear-cut guidelines. Secondly, medical science is a constantly evolving science. You're always going to have new diseases, you're always going to have new treatments. I personally feel this guideline when it came into force, CABG and angioplasties were relatively newer procedures. We did not have much experience with them. That is why there was a tendency that these patients may need emergency evacuation. But clinically, what our experience has been, we don't require that intensive a follow-up if an angioplasty patient is doing well. But again, this is an issue that needs to be solved at the level of the regulator, where guidelines have to be updated in a time-bound manner. Somebody who is unfit now, as per the current guidelines, treatments have improved, new treatment has come up, guidelines need to take that into effect, and maybe he'll become fit. Expert opinion needs to be taken into consideration. So there is the subjectivity needs to be removed. I would totally agree with Dr. Barfiwala sir that this is what causes a lot of ambiguity at times, different guidelines, and different things saying different things. So one more point, as we were just realizing with the discussion, if somebody is hypertensive and he's taking medication, if somebody is diabetic, he's taking medication, somebody has asthma, he's taking inhaler before going to the doctor's office, somebody has epilepsy, he's taking medication, somebody has mental illness, he's taking medication, not declaring. The doctor will always be on a back foot. It's virtually impossible to detect such conditions until and unless the seafarer gives you some clue in his history. It's virtually impossible. So based on that knowledge, do we have some mechanism whereby there is some stick that if a seafarer is caught and he lied on his declaration, are you going to possibly, bar him for joining any company? Because if a sportsman refuses a drug and alcohol, a drug testing, or he's caught positive, he's not going to play for his international team or club cricket or whatever for next, 1 year, 2 years. But over here, the seafarer does not have any incentive to not to lie. He has all the incentive only to lie.
You have certainly raised some issues. So we are 6 minutes already.
Another example of this point would be, I have seen a patient today. I have declared him temporary unfit. I have advised him to come for a review after 3 weeks. We find many such patients who never come back for a review.
Absolutely.
So our understanding is they've probably gone to some other doctor, maybe to a smaller place or something, and they've managed to hide the fact that they had that fitness and they've gotten the fitness.
Absolutely.
So we need to have a mechanism where a PEME that has started and a seafarer has been declared unfit by a DG approved doctor, somewhere that data needs to be entered. And if a patient is coming to me, if a seafarer is coming to me, I need to first make sure that he has not been declared unfit by somebody else. There are certain PNI clubs, right? There are certain PNI clubs who basically operate in this way. They have a registration of Part A, Part B. The purpose of Part A is that first you do the registration, and this seafarer does not have any ongoing PEME. Only then proceed with the fresh PEME. So my point is, there is a lot of vacuum. It's okay to say that at the end of the day, the doctor has to decide. But the problem is that gives rise to all kinds of subjectivity. And at the end of the day, that is what happens, that if you are giving fitness, you are hero. And if you are not giving fitness, you are zero.
So that is the problem. Absolutely. And mind you, if this, let's not only talk about the seafarer. The companies are no saints in this. I'll be blunt in that. There are companies who will put pressure on the doctor to say, जाने दो 2 दिन में वापस आ जाएगा, 2 महीने में वापस आ जाएगा. होता है ये. Okay, I think we are 8 minutes over time.
I just 1 minute. We can leave 1 minute late. Actually, the point taken by him is very relevant. And what we have been discussing here mostly toward 10 pre-employment medical examination and lots of grey area. I think it's high time, sir. Maybe now you are a regulator. You are the top boss. You consult some doctors, call them. And make, like for transgender, you call doctor, you do autism. It was well thought of process. Why not this? And this has more implications for us. That is my first point, request to you. Second point, sir, we are only talking about payment. What about the on-board care? I hope the next panel will talk about it. I briefly said, when the seafarer goes on board, payment is finished. What then? He is spending 6 to 9 months on board. We do duty of care. We spend lots of money, lots of things on mental wellness, on his exercises, on counseling, on good food. It's not only the medical thing. Surely, proper food, proper water, interaction, that also plays a part for the wellness of the seafarer. I hope the next panel will take it over. But that is the closest point to my heart. Most of us sitting here are the manpower employer. Of course, not only the doctor. So that's what I want to say. Thank you.
Thank you. Thank you very much, doctor. But doctor, when you raise, sorry? Ma'am, no chai for you. Okay. One last question. Oh, you? Okay. Mike. You are standing under the lights. I can't. Yeah. Okay.
Thank you so much for this opportunity.
So, thank you so much for hearing me. So with the...
1 minute. He's under the light, I couldn't see him.
It was a very valid and important question which was raised a while ago about angioplasty and what happened. The regulations, what regulations do we have? In fact, the problem or the difficulty that we are facing here is our senior doctors, they have whatever they said is absolutely in black and white incorrect. But still there are confusion because we have various standards as sir rightly said. We have EG guidelines, MS notice, we have ILO, we have P&I clubs, and then we have company. Company has their own HSE policy and they decide where they want to sit. Either they can be the lowest ILO guidelines, a little above EG, MS notice, or they can decide to have enhanced PME like P&I clubs, or they can have their own enhanced PME. Angioplasty cases, in terms of ILO medicals also, the most basic medicals, they are restricted to coastal waters only. It's in black and white. Why we say it is in black and white? Yes, Amendment 2016, it is a short document. It does not list down every medical condition, which it says that we cannot list down every medical condition. But what it does, it calls doctor for familiarization courses. When they call doctor for familiarization courses, they give this booklet. And that booklet is, for some reason, not being given that much importance that it needs. And that booklet does say, it defines ICD codes and it tells what to be done with each particular disease. Where it doesn't, it says clinical, the doctor is the best judge. But then when it says that, it also says every medical condition which has got likelihood of aggravation is a reason of unfitness. So whether it is mentioned on the guideline or not, if we feel that it is a medical condition which has got likelihood of aggravation, like a dental cavity, it is unfit. So what can happen in cases of angioplasty? Can they go for sailing in foreign waters? Even the regulation doesn't allow, they can still go. The companies can do an exception. Like a very reputed company, they got their doctors from their headquarters involved. They got the case discussed. So it is called case-to-case assessment. And this guy is still sailing in foreign waters, even though he had angioplasty.
Yes. So, yeah, and mind you, just to add on, the certificate under this Amendment 2016, Clause B, states that the seafarer concerned is not suffering from any medical condition likely to be aggravated by the service or CO to render seafarer unfitted. It's there, the statement does exist. Yeah. But there is a subjectivity. Because that is where you have to do, I think 13 minutes over time. They're going to take away my samosas also now.
One question. So does that mean that the ship owner can override the guidelines?
Ship owners?
No. Doctor, the ship owner can override guidelines if you sign it.
No, I'm not signing, but the ILO guidelines, do not say case-to-case assessment in case of angioplasty or coronary artery bypass.
Let us
very clear qualified, not
it says every case. Every case.
One moment, please. I think we can carry on this conversation over chai. Yeah. No, not this. Over tea. Over drinks you get into fights. No, tea. So, and ma'am, you had one question which, yes.
So, with so many stalwarts sitting around over here, and there's so many grey areas that are existing and that are being discussed. So, can we have a forum or some kind of a platform where, whenever we face any difficulty as a medical examiner, could we discuss this or seek some kind of an advice or a guideline? So, overall, a kind of standardization also would be maintained. Is it possible?
Basically, an advisory board?
Not really, you can't, but somewhere where we can just post our questions and we can seek some kind of a help, because there are so many things which are not, as he rightly said, that there is a vacuum, there are grey areas, we do not know. So something like that, can it be done? Or is it possible to have a forum like that?
We have 15 minutes over time. I can answer, but I will not answer. For a reason. The moment we get into what you are asking, if we ask the regulator to do, the repercussion will be something else altogether. The maybe the answer then is amongst you doctors, you get together and sort it out. Just as we
this is
have,
a question to Dr. Belani and Dr.
Wonderful.
Dr. Singh. Yeah.
just as you know, the shipping companies here, many of them are members of association. And the association actually does exactly what you are saying, not for medical, but for a lot of other things where we do consult and we do guide people. We do that. Thanks. And I think we will finish it. We are already past. Sorry?
See, Captain Nitin Mukesh, one query, last query. Sorry for delaying the team. Suppose some seafarer is aggrieved by the decision of the medical clinic or the doctor, and he goes to the appellate body, and the appellate body sends him to the standing board, which generally they send to JJ Hospital, and there he is declared fit. Then what happens?
Fit, no? Then he's fit.
No, I am saying because we have had many cases of coronary angioplasty where they have been declared fit by the standing board at JJ Hospital. And standing board, as per all your circulars and others, are unfit cases. But they have been declared fit by the standing board.
Then they are fit, sir.
No, they are writing fit for sea. And then the shipping master who was DSCO, he used to give him as fit. Dr. Belani will be knowing it. Many of the senior doctors.
After they have been declared fit, they have to go to DSCO. DSCO as per the medical examination rule. And they are fit for the sea. It has been declared by the judge. Because that is a panel of the doctors, not one doctor is doing it.
Thank you.
JJ Hospital doesn't have DG approved doctors.
Okay, thank you very much. We are 17 minutes over the time. Thank you very much. And you know, the fact that we are 17, I had actually started taking notes initially to do a summing up, but we are 17 minutes over time. That's my summing up. And you know, when you are so much over the time, either there are one of two possibilities. There are two possibilities actually. Either the panel discussion was very interesting and that's why it went over, or it was poorly conducted. So we'll leave the choice to you. Okay? Thank you very much. Thank you. You've been patient.
Requesting the panelists to please stay back, and I invite on stage Captain Rajesh Tandon to present a small token of appreciation for the wonderful discussions we had today to our panelists and moderators. Please sir, can you do the honors? So we have Dr. Dushyant Parfiwala sir. Captain Nitin Mukesh. Dr. Ramesh Nair. Captain M.P. Basin sir. Dr. Vijay Belani. And our moderator, Captain S.M. Halve. Can we have a group photograph, please? If you can just come a little bit ahead for a group photo.